Neuropsychiatrist Dr. Saad Shaker is going to help us better understand the many kinds of mental disorders. I'm Marilyn Priel with The Better Part. Stay with us. In his series of visits with us, Dr. Shaker has told us about neurological and hormonal disorders which affect people emotionally and physically. Specifically, there were ADHD, depression, anxiety, and bipolar disorders. I'm asking him now to explain some other mental conditions that the average person wonders about but doesn't understand. Welcome, Dr. Shaker. Thanks for coming again.
Thank you. I'm very happy to be with you again.
Let's just start right off and tell us what is neurotic.
So that term we try not to use much these days.
I know you don't like any of my terms, but people my age, those are the ones we grew up knowing.
So that's the history, yes. So if you look at back in history, in the 1950s and 60s, they would classify neurosis and psychosis. We've really come a long ways from that. But what it really means to me when I hear that is non-psychotic, non-serious mental illness. People who have more personality characteristics or excessive worry or anxiety, but not bordering on dysfunctionality or impairment of reality or judgment. So it includes like personality disorders, anxiety disorders, not schizophrenia, not bipolar, but less serious medical or mental conditions.
So then what is psychotic?
Psychotic is impairment of judgment and a loss of touch with reality. And generally in the old term psychosis, and still does, it's a higher level of impairment and severity. And oftentimes these are individuals who need a higher level of care, including medications, sometimes more residential treatment, and so on. So there are people who have a world of their own sometimes inside their head that might not be connected with outside reality.
Okay, and then now obsessions. What are obsessions as compared to compulsions?
So obsessions are defined as repeated thoughts. Compulsions are repeated behaviors.
Okay.
If you have a disorder of obsessive compulsive disorder, it's now classified in the new diagnostic manual of psychiatry by the APA as a separate entity. It used to be part of the anxiety disorder. But these are individuals who have to meet criteria of uncontrollable repeated thoughts, ruminations. Compulsive behaviors, example would be compulsive hand washing, and is associated with fear of contamination or dirt. If someone touches anything, they wash several times thinking they got some germs. Germ phobia. Compulsive counting. I have some patients I catch looking at my blinds, and they're actually counting how many panes on the blinds. Compulsive number details. You know, there are some people who memorize all the athletic scores and details and so on because they have like an encyclopedia privately. They have a need for details on a subject they have an interest in. Drug use. There is compulsive hand washing. There's compulsive sexuality. Nowadays people are getting hooked on porno, internet, compulsive behaviors in children, manifesting with behavioral disorders, like they have to be meticulous or they have to take certain steps. So that's an example of a compulsive behavior. And sometimes people have a mild version which fits under a personality disorder. And I assure people, obsessive compulsive personality disorder is OPD rather than OCD. It's actually a nice, if you're going to have any personality disorder, that's nice to have because you're reliable, conscientious, hardworking, and hey, we're in Silicon Valley. These are superstars in companies usually. They work long hours. We have to be careful because otherwise you're going to be labeling everyone with mental illness, which is not obviously not that
Well,
bad.
let's say it gets out of hand then. Do these things get out of hand?
Yes, if you have an obsessive compulsive disorder, it's a definite diagnosis. We have objective criteria. Yeah, so when we look at diagnosis, we follow the manual provided by the American Psychiatric Association. And it changes every 10 to 15 years. The latest version is what's called the Diagnostic Statistical Manual of Psychiatry, Volume 5. So if you have someone with obsessive compulsive disorder, we diagnose it through clinical interview. We also have rating scales. If they meet the criteria, then we treat it as such.
What about hoarding?
Hoarding now in the new diagnostic manual is actually got its own category under obsessive compulsive disorder. Hoarding is oftentimes a very tough situation, not for the individual as much as family members. These are individuals who attach value to every item in their life. They have clippings from papers from 20, 30 years ago. They have books. They have napkins from restaurants. So they collect massive amounts of material. And oftentimes they run out of storage space. They go out and rent storage space. I've had people where their spouse comes in and says, it's driving me crazy. Now we have a 4-bedroom house. Now all I have is 6 by 6 that doesn't have clutter in it. And it's really a very disabling condition, hoarding disorder.
Is it sometimes like that? From watching the shows on television about hoarding, it seems like it's people who are lacking something in their life, or a loss or something. It gives them kind of an identity to acquire these things, and they kind of get a thrill out of acquisitions.
That could be the psychological theory, could be partly related to that. Sometimes it is related to biological and medical conditions, like they have an imbalance in the circuits in the brain that controls serotonin. But sometimes it could be related to childhood trauma, you know, that they might have discovered a behavior that comforts them, and they start doing it over and over again. So there's really, it's important in my field, it's rare to see the same thing in every person every time. So you really have to take a fresh look at each person and how that fits in their life and where it came from.
When it gets very difficult then for them to get rid of something, is then that more like is there such a condition as inability to make decisions?
So yes, the answer, indecisiveness is a symptom for many conditions. But let me address the compulsive hoarding issue that you have. So normally when you have a person who tells you, I'm collecting that, you ask them, why are you having an article from 30 years ago? They always have an answer saying, oh, what if one day I need to access it? And then you tell them about computer technology and all that. They said, well, they might not have the actual article that I need to refer to. Oftentimes what they collect, they really don't even look at, but it gives them a sense of security and confidence. So why do they do it? Is because if they don't, they get highly anxious. So oftentimes when we treat someone like that, we do it in gradual fashion, what's called desensitization, because usually there's a lot of underlying anxiety that emerges if you tell a hoarder, I'm going to remodel your home, and you have nothing to do with it. You actually really can induce a big crisis in that individual. So you have to see how it fits, what the treatment is. Sometimes it involves medication, behavioral therapy. Oftentimes marriage counseling is significant because, as I said, if the hoarder is comfortable with the hoarding, they're not the one who are going to come to you. It's their significant other who's going to say it drives them crazy.
And then there's the compulsion, I think it's compulsion stalkers, like these people who follow for instance, a movie star, and go from performance to performance, from city to city, and actually learning everything about them and following them. And is that a compulsion?
Well, that's actually a more serious mental condition and could span across. They can have a delusional quality, so they can have false belief. They might feel that that particular person, when they appear on a show, is giving them a certain signal. So obviously that person with that belief system has a more serious mental disorder than someone who is obsessed with a movie movie star, but not really following them from show to show. So I think you need to recognize there are some people who are socially impaired sometimes. Those are the ones who would track potential victims or the predators with sexual abuse. Those are the individuals who are at a high risk of legal or psychiatric complications.
And then like pedophiles.
Well, that's also a serious sexual disorder. There are a lot of paraphilias and sexual disorders. Pedophiles are the ones who are unfortunately obsessed with children and child pornography and behaviors related to sexual behaviors related to children. And
so it is a compulsion then, more or less?
No, I don't really. I think it's a disease, it's an illness. Compulsion implies the behavior itself.
Behavior.
But a lot of times people do it willingly and consciously and get a thrill or excitement. So it's not quite a compulsion alone. So I would like you to separate those two. My goal is really to try to bring into light that the diagnosis is no longer a labeling process. We have ways now we deal with those conditions. And the good news is we have treatments that are very effective.
But let's talk about a little more about delusions.
So delusions,
What are,
by definition, is an attachment to a false belief. The person who has a delusion is convinced with a belief system that does not fit by external reality. For example, somebody is delusional about the world coming to an end tomorrow or next month, or they have a delusion that they are such important people that they're being tracked by a Central Intelligence Agency or FBI. So it's a belief system that's real to them. Or they live in a safe neighborhood, but they are delusional about the danger in that neighborhood. They put 6 locks on their door. So delusion is a belief system that's not fitting with outside reality. It could be, most of the times it is associated with mental illness, a psychotic disorder, schizophrenia, bipolar, but there are some people who have a delusional disorder without schizophrenia or bipolar, a fixed delusional disorder. Like sometimes they could be functioning in an industry and they have a fixed belief system that does not disable them, but they would, for example, never go to a restaurant. And you ask them, why would you not do that? He said, because I am convinced that in restaurants people put you trash or poison or something. And there's no reality to that effect, but that's a circumscribed delusional system.
And then I guess you hear about delusions of grandeur. Would that be like people who think they have a connection with God, a special connection? Or I'm even thinking of like people like Napoleon and Hitler, people who thought they had a destiny. Would they have been maybe delusional to some extent?
No, that's a good point. Grandiose delusions is what we call them now, which is often associated with an inflated sense of self to a very high degree, thinking that they're the center of the world and that they are more important than an average. So that behavior, if it's consistent, could be part of a chronic psychotic disorder. But episodic grandiose delusions are very common in a bipolar disorder in the context of mania. For example, if you see someone who was admitted during a manic episode with, and by the way, let me also say, not every bipolar has psychotic delusions. Statistically, less than 30% of them do. But if you see that 30% in an acute setting, they would say, and you tell them, why were you standing at the corner naked and talking to yourself? So, no, I wasn't talking to myself. I was talking to God or Jesus Christ, and they were giving me special messages because I'm their messenger. So when you ask them, they tell you a belief system that is inflated and grandiose. But they're convinced. If you tell them, no, that's not reality, they get agitated and concerned. So milder version of that can appear in non-psychotic individuals. For example, if you're a politician and I'm not, you can look at TV and say, oh boy, that person is full of themselves. And sometimes they're actually full of themselves. And they believe they are God's gift to humanity, but they're running for a political office. So a milder version. These are not individuals that are picked up on the highway and taken to a psychiatric unit usually, but they can be more dangerous in other ways.
There's one lady in particular that I see at a place that I visit, and she talks to somebody next to her, and she'll have conversations and go back and forth. Sometimes she become very angry, or sometimes just laugh and have this wonderful, marvelous rapport with whoever this is. Is she delusional?
This person you're talking about is hallucinating. Hallucinations is hearing things or seeing things. And it's often associated with either chronic mental illness, or sometimes acute hallucinations could be related to drug overdose or substance abuse, especially psychedelic drugs, hallucinogens. But most of the time we look at it as part of pathology, and if someone is psychotic, we treat their psychosis until we control them.
Sometimes, like, they see things, like they might see a lion up in a tree, and nobody else sees the lion, but they're hallucinating and seeing that. Or strange things that no one else in the room sees.
Let me address a little more detail there. Usually visual hallucinations, as a doctor, I worry more about. They are sometimes related to brain pathology. In other words, they might have a delirium, or might have chronic alcohol that affected their brain, or they might have a type of dementia that's causing visual hallucinations. So if I have someone with visual hallucinations only, I would do a neurological workup on them. It could be a brain tumor. The commoner ones in schizophrenic and chronic mental illness is the auditory hallucinations. But there are also tactile hallucinations, people feeling that something they're crawling on their skin.
Paranoia and persecution complexes, are those the same thing or different things, and where would you find those
So I would like you to look at that as a spectrum. Mild paranoia is suspiciousness. It could be part of a personality disorder. You sometimes see people who are more guarded and suspicious, but they're not delusional. They might feel, they might tell you, you know, the world is an unsafe place, but you tell them, you know, tell me more. They don't have a formulated idea that somebody's going to come and attack them or invade them. They're more suspicious. So that's mild paranoia. But it can overlap with obsessive-compulsive spectrum and psychotic disorders. So paranoid delusions are very common delusions in a psychotic disorder. The content of the paranoia is usually persecution. It's like, I'm being followed because they think I'm a spy, or I am this. So usually they feel that there's something negative that causes them to be the target of this persecution. But paranoia could be a personality trait, which is not that common, but happens, or it could be part of a severe mental illness.
Tell us about schizophrenia then.
So schizophrenia has been recognized for a long time as a chronic mental illness that's associated to wiring issues and chemical imbalance in the brain. Behaviorally, it can disrupt functionality. However, let me also say even schizophrenia has good news. Nowadays, we see less chronic disability from schizophrenia because we have more likely acute interventions that are very effective. Like years ago when I did inpatient psychiatry, I would have people who'd be admitted with an acute psychotic disorder that looks schizophrenic and hallucinations, delusions. With aggressive acute treatment, people can recover. So it's not as bad as it used to be, but if you see someone who's had it for many years and has chronic disability from it, we do have rehabilitation models, we have newer medications available, but it's a chronic mental disorder that can affect their belief system and functionality. Many of them can be impaired from functioning and might be on disabilities.
What would be the symptoms? You said delusions and hallucinations and just...
So there are 4 clusters of symptoms that can manifest in schizophrenic. So belief system, so their thought content, so that is similar to what we talked about earlier. They can have delusions, hallucinations, or combined. They can have impairment in their affect, which means their mood. They're less likely to be engaged in a normal emotional interaction as people are, so they might seem flat, controlled, or bored-like, and what's called flat affect. It might affect more ambivalence. You asked me earlier a question about indecision. That's a common presentation in schizophrenic. You tell them, do you want to have this kind of food or this kind of food? Oh, and then they get stuck. So they have difficulty with ambivalence, affect, ambivalence, anhedonia. Anhedonia is also described as lack of interest in activity. So they have a feeling of being burned out. You might say, do you get excited about a football game that you go, nah, no, I mean, they seem flat, unmotivated, lack of connectiveness to excitement, for example. So those are called the negative symptoms. So if you look at classification of schizophrenia, you hear terms of positive symptoms and negative symptoms. Positive symptoms refers to an acute thought disorder with hallucinations, delusions. Negative symptoms is the sense of being burned out, ambivalent, unmotivated. And in the pharmacology world, there's been a big shift since the 1990s. Some of the newer medications available seem to be more effective on the negative symptoms also, not just the positive.
What's paraphrenic?
Paraphrenic is a psychotic disorder, but it's compartmentalized, and it's not associated with the same degree of impairment in life functioning like a schizophrenic would be. So it's a more milder version, if you will, and some of the paraphrenics are people who are in society, but they have a fixed belief system that's not connected to outside reality, usually of a paranoid nature.
Something that, you know, we hear a little bit about more in the movies, I guess, than anything else, but multiple personalities. Would that be something that's in schizophrenia, or is it something else?
Not really. I mean, a lot of people lump multiple personality with what used to be called split personality. Mm-hmm. The old term for schizophrenia and the late term was split personality. Multiple personality has a diagnosis category by itself. Now we call it dissociative disorder. So this is your bedtime reading tonight, Marilyn, in this book. Go to the section on dissociative disorder. But to be more serious about it, dissociative disorder can include multiple personality, but a milder version, amnesia, what's called the amnestic dissociation, it's often associated, not always, but often associated with trauma, childhood trauma. If you see someone who's had multiple physical or sexual abuse, it's not uncommon that they survived by repressing some of those memories. So they have compartmentalized memories in different segments in their unconscious. So in severe cases, it manifests as multiple personality, where one personality doesn't know about the other. Milder dissociative disorders are very common. We see it overlapping with other conditions. You know, oftentimes we see individuals who have PTSD from childhood sexual abuse, for example.
And so PTSD, you know, I'm thinking mainly of, you know, vets and different things. It could be anything, a serious accident that people kind of relive. That's not a mental illness, really. That's just something that's the brain does a playback or something.
Well, I think, let me kind of, two things. Post-traumatic stress disorder is classified as a psychiatric disorder, but response to trauma is not a mental illness. For example, that might be a lecture of its own, but not. So I'll mention, let's look at sexual abuse. So based on a survey, if you look at the percentage of men and women who have sexual abuse in their childhood, the percentage is higher in women than men. However, the incidence of post-traumatic disorder is among those who've had sexual abuse is higher in men. So a higher percentage will develop. So post-traumatic stress disorder is a psychiatric disorder. For example, a lot of veterans go to and come back from war. They've been in trauma, but they don't have the diagnostic criteria of PTSD, which includes hyperarousal, dissociation, forgetfulness, amnesia, and mood symptoms. So sometimes overreactivity situations. So to have PTSD, you really have to meet the criteria on PTSD.
I wanted to ask you about severe rage. People just have out of control rage.
So you classified it as severe rage. Rage is an emotional reaction, often associated with anger. If you have extreme loss of control of anger, it could be associated with psychiatric diagnosis. For example, if you have someone in an acute manic state, they can be grandiose, as we discussed earlier, or they can be rageful and violent and put holes in walls or attack people. So rage is a pathological emotion that can be, but also it's associated sometimes with non-psychotic disorder. You have explosive disorder, you have conduct disorder. These are non-psychotic disorder, but people have an enormous amount of anger and rage that manifests in an inappropriate way. It could be antisocial personalities. Sometimes or narcissistic personalities can be associated with a sense of entitlement, and if you cross them the wrong way, they might get rageful.
We know that the possibility of mental illnesses can be carried in certain genes that will be activated by a particular catalyst or something. It runs in families. How is it that one member or two members of a family will get it and none of the other members do?
How much time do we have? No, seriously, this is a whole field. Actually, I'm participating in an international convention in October to present a paper on pharmacogenomics. But the genetics in mental illness are very significant because we've known very little about them. So you could have a recessive gene or a dominant gene. You could have a cross gene. So and you could be, there's a phenomenon called epigenetics. Epigenetics means if you have a twin, let's say a set of twins, and they're raised separately, they have the same gene. One of them develops the illness, one doesn't. So epigenetics would be environmental exposure, toxins in the environment, stress, trauma, smoking. So epigenetics means the environmental issues that trigger So not every genetics manifests 100% in the next generation, and it could be recessive or dominant. So there's a lot of research now. For example, in ADHD, there's a lot of data now that has been done to look at which chromosome. So like 7 and 11 on the dopamine receptors and norepinephrine. I know that's sounding technical, but it's really the tip of the science iceberg of genetics in mental illness.
Well, these people, they lead such tumultuous lives, and it must be very difficult to treat them, but it seems like there are more and more things coming about that can help them, and you're one of the people who seems to be able to do that. So thank you for telling us about it, and thank you for your profession.
So thank you for the opportunity to speak to your audience on this topic.
Thank you for joining us. I'm sure you learned a lot on this program. We're very happy you came, and we'll see you next time. Goodbye for now.